Thank you. These are my disclosures. So this kind of messed up there. So as Paul alluded to, I think the goal of hip preservation surgery long-term is to delay the onset of osteoarthritis. And a lot of us feel that biochemical imaging could be a surrogate marker to detect early change so that you don't have to wait 20 years to see your end result. With MR, the idea is to try and use the MRI as your microscope to pretty much try and look at the cartilage in a microstructure or histologic way. So the idea, and we actually have many different biochemical imaging techniques available. So T2 is the one that I will talk about. It can look at collagen matrix structure as well as hydration of the cartilage. And then dGEMRIC is a technique to look at the proteoglycan content using gadolinium as your histologic stain, so to speak. And obviously, Paul talked about T1-Rho, which is shows a mixture of T2 effects as well as looking at proteoglycan content, and I won't go into more detail than that. So I'm going to first explain the dGEMRIC technique. I think a lot of you know about this technique. It utilizes the fact that in early osteoarthritis, proteoglycan is lost because of the catabolic effect, and that's what you're trying to measure using the MR scan. As you know, all techniques, including MR and histologic techniques to measure charge, use a stain. If you're doing a bioassay, DMMB is basically a stain that allows you to look at charge density. You could also do toluidine blue using histologic methods. So when you talk about dGEMRIC, you're actually using your gadolinium, which is negatively charged, as your stain, and your MRI is your microscope to look at the image. So I'm going to show you some examples of some of the non-contrast techniques, T1-Rho, T2, and T2 star. This is courtesy of Dr. Cohen from Ottawa, and as you can see, you can see subtle changes in the cartilage T1-Rho value with in the different layers of the joint. And T2 star is a similar technique to T2, except it's a three-dimensional technique, and it doesn't quite measure T2 relaxation time, but it gives you similar effects. And Christoph Zirkens and Bern from Düsseldorf has shown the value of that in impingement cases. Now I'm going to concentrate on T2 mapping. It's actually the oldest biochemical imaging technique. It is a non-contrast technique, so you don't need to give contrast to get this T2 effect. And people have hypothesized that in OA, when you see hypertrophy or increased hydration of the cartilage, you will see prolongation of T2. And also, when you see disruption of collagen structure, that will also alter the T2 value in your image. dGEMRIC, I've used it for a long time, and we've shown value in patient selection for especially in the dysplasia cases. We've also published studies using that as a biomarker for looking at the hip joint after osteotomy. Right now, there is a commercially available T1 mapping technique that you could do fast T1 mapping for dGEMRIC. However, it does require IV gadolinium injection. And as you know, there's a lot of controversy about the deposition of heavy metal in brain tissue and also toxicity to kidneys. Hence, there's a resurgent, there's still a persistent strong interest in some kind of non-contrast technique. Now, I have to tell you, I come from a center that's biased against some of these non-contrast techniques because there are many in vitro studies that show that especially T2 effects can be quite variable depending on how your matrix changes. So we wanted to do a direct head-to-head comparison between dGEMRIC and T2. Fortunately, you can measure T2 in the presence of contrast, so that can be done quite effectively. Now, when we think about how to analyze these data, you have to understand how the T2 values can change, sometimes simply with the positioning of the patient in the magnetic field. There's something called a magic angle effect where the highly organized collagen fibers, depending on the orientation in the magnetic field, their values can change. And this effect has been nicely shown by Dr. Watanabe and actually Klaus Siebenrock, where they took healthy volunteers and they simply imaged it in a 3T scanner. And they looked at the value of the T2 signal depending on the position of the cartilage, the angle of the cartilage against the magnetic field. And what they have found is that, fortunately for us, if you look in a narrow range, so in the weight-bearing portion of the joint, the T2, the magic angle effects are minimal. However, if you start to look at the femoral head cartilage in the 40 to 50 degree angle from the B0 magnetic field, you will see significant elongation of the T2 value, which is likely due to the magic angle effect. However, this effect is complex because you see the magic angle effect only in the deep layer of the femoral head cartilage, and you don't really see it on the acetabular side. Hence the complex nature of T2 result interpretation. Additionally, there has been studies comparing FAI patients compared to control patients using both T2 and T1. This study is from UCSF. And interestingly, when you look at global changes of T2, they did not see any significant change on the acetabular side. They saw prolongation of T2 on the femoral side. And they stated that if you do regional analysis, it may be more sensitive. And this is similar to our dGEMRIC experience, where often in impingement patients, the changes are very focal in impingement, whereas in the dysplastic case, the changes are often global within the joint. This is a study looking at dGEMRIC variation within the joint from Düsseldorf. And again, there is some regional variation, both in the disease state as well as the control hips, depending on the location of the joint. Fortunately, the femoral head cartilage dGEMRIC values are fairly constant, as shown here. Hence, at least for dGEMRIC, we can use femoral head cartilage dGEMRIC as an internal control to take into account some of the normal variation that you may see in dGEMRIC values depending on activity level and such. So this is a long-winded way of coming around to saying how we develop an analysis scheme. So our goal was to compare on the same hip the changes that you will see in impingement cases between dGEMRIC and T2. So we wanted to actually optimize the detection of the change. So I really tried to skew the analysis so that we can detect the change. And that was done by, and I'll explain how we did that anyway. So this was all done on 3T scanner. This is the range of patients. They were all surgical cases. We do have some intraoperative damage assessment. These were straightforward primary cases of impingement. None of the unusual pediatric deformities were included. So in total, there was 32 hips included in this group. So because T2 mapping is fairly time intensive, we were limited in terms of the number of images that we could acquire. So both dGEMRIC and T2 maps were done in the sagittal plane, and we also had high resolution morphologic imaging, both imaged on the coronal and sagittal images, sagittal planes. Now, the commercially available T2 mapping protocol from Siemens was inadequate. So that's a word of caution for people that want to go home and try this using off-the-shelf software. It produced images that were too noisy and too variable, so we developed our own T2 fitting algorithm, which gave fairly good results. So in terms of quantification, what we did was on the morphologic scans, you could identify the labral conjunction separation, and based on clinical information, we know that there will be damage at the cartilage layer on the acetabular side, just next to the labral conjunction separation. So first, on the morphologic images, we identify these areas, and then on the dGEMRIC maps and the T2 maps, we measured the dGEMRIC values on the acetabular side and the femoral side in these adjacent areas. All right, so this is the data. and this is very preliminary data. What we found is that on the dGEMRIC scans, the acetabular cartilage values were lower, significantly lower, compared to the femoral side. And this is what we would expect based on the morphologic change. So these are areas with right next to the labral junction separation. I think clinicians would agree with that. Now, for T2, we also found a change, a difference between the femoral side as well as the acetabular side. But there was a decrease in T2. So if you expect hypertrophy or degeneration in a typical OA, you would see prolongation of T2. But we actually saw a decrease in T2, and it was significant. We did not see correlation between T2 and dGEMRIC in itself, which is expected because dGEMRIC measures proteoglycan content and T2 pretty much measures collagen or hydration. So that was not unusual. That was expected. So what does this all mean? So I think dGEMRIC is easier to interpret. So lower proteoglycan content usually leads to lower dGEMRIC, and that is what we found. And after a certain level of low dGEMRIC, we know that it can be pathologic. So if you look at the data again and use 400 milliseconds as a sort of a cutoff, and we have data supporting that this may be a true pathologic range, you can see that on the acetabular side, there are some hips with true pathologic change. Now, it is difficult to say that about T2 because T2 can't, if you have matrix increased hydration, you would see prolongation of T2. But there's also basic science data from Bern saying that Mankin scores can inversely correlate with T2. Hence, if you get more damage, you may see a decrease in T2. So which way does it change? It's hard to know. In addition, there are clinical studies from Vail and from UCSF showing that there's significant regional variation of T2 within the joint, and there's also differences between femoral side of the T2 as well as acetabular side of T2. So I think in the end, I think dGEMRIC and T2 may show complementary effects within the joint. I think still dGEMRIC, despite having to give contrast, is probably a simpler analysis. However, when you're trying to look at T2, I think you have to do it very carefully, look at very specific regions, and you may even need normative data for that particular region in order to understand how you can interpret T2 change. Thank you very much.
Thank you very much, Young Cho.